All right, it's 8 o'clock, and so we are going to get going this morning. Welcome to the webinar with Gerard Gioia this morning, and I will introduce him really quickly. Oops, hold on. There we go. All right, I got a notification. Sorry about that. Good morning. We are going to start our webinar, Managing the Complexity of Concussions in Schools, with Dr. Gerard Gioia. He is a good friend of Siebert. I will let him introduce himself. I don't need to go into his background too much. He'll do that. And away we go. Thank you.
All right, good. Thanks, Melissa, and thanks
Sure.
to my Siebert friends and colleagues, and welcome to all of you here this morning. So I, again, am Gerard Gioia, and I am a pediatric neuropsychologist. For those of us that are working in the schools, I was formerly a school psychologist before I went on for my fellowship in pediatric neuropsychology, and try to pride myself in having walked the walk, and seen exactly the challenges that we all face in corralling all of the students in schools. I run the concussion program here at Children's National. We have had this program now for 20 years and see both patients and families, as well as conduct research and train people, and do a fair amount of community outreach. It's a field that, as I talk about this morning, has definitely advanced over the years, but we still have some ways to go. Disclosures here, one of the things that I do is develop measures. I may talk about the post-concussion symptom inventory, but I'll probably be talking mostly about other measures that have no association with royalties or anything like that. I think one of the challenges that we face with brain injury is that visible versus invisible injury issue here. And, if we think about an orthopedic injury and somebody coming in with a sling on, or, with crutches or a cast or something, we automatically sort of understand that that is an individual that may have some challenges. And most of us will have some empathic kind of feeling associated with that. Brain injury sometimes, though, can fool us. And the complexity of understanding something that is invisible is a challenge. And there are times when I talk with kids about that because they feel like they're not well understood. And I say, well, we'll put a bandage around your head, and that way we'll at least show people there. So, understanding and managing, I think, the invisible, I would argue, is certainly challenging. Not that an orthopedic injury is to be taken lightly, though, but so I want to give this. I gave this this part of this presentation last April in person in Bend, but I'd like you to consider, if you were to break your leg at a work-related event, the broken leg is diagnosed at the emergency room, your primary care doctor is informed, but nobody tells anybody at work. Your job is to stand on your legs and teach or do things in the schools for 8 hours a day. But nobody at your job really understands what that broken leg is about or how it affects your job performance. And you're supposed to do your job. And no complaining, no supports. But people can't quite figure out why you're limping. Pain is pretty significant. But you try not to let anybody know. You really try to tough it out, and you're dedicated. But you're worried. And by the way, you're supposed to play on the company softball team after work today. So that's just an example of an orthopedic question or orthopedic injury. But how would you feel with all this? You might feel stressed, misunderstood, ineffective. But let's now think about a student who sustains a concussion at some school-related event. We know that sports and other kind of activities, they occur. The concussion is diagnosed at the emergency room. Your primary care doctor is informed, but no one tells the school about this. So the job of the student is to use his brain and to get in there and do the best job they can. No one at school really understands what that injury is all about or how it affects your academic performance. But you're expected to do your job and to learn and perform without any supports. But no one understands why you've got these headaches and why you're tired, why you're having troubles concentrating. And it's pretty significant, and you're drained. But again, you try not to let anybody know you're a dedicated student here. But you're worried because you were supposed to play on a softball team after school today. So how again would you feel if you sort of enter this environment of a lack of understanding? Might you feel a tad stressed, misunderstood, or ineffective? So what my plan today is to really talk about what this injury is, and to some extent what it's not. Talk about the typical kind of course of recovery, when we want to get kids back into school, but how we want to define, the way that it plays out academically and how to identify those issues because it varies from person to person. And then really how to build a targeted academic kind of support system that really helps the student through their recovery and also to learn. Um, and why it's important to really follow over time and monitor the progress, and have good communication, not only within the school, but with the healthcare providers. So, the I've been doing brain injury work now for a long time. Back in the 80s is when I started. And so the question is, how have we gotten to where we go today? We certainly know that understanding this concussion, mild TBI thing has progressed over the years and really started with adults, as most do. And then we realized, oh, it happens in kids. And yet, what we all know in working with kids is that development is a moving target. And that brings us challenges here. We then moved into kind of figuring out how do we diagnose this? How do we develop tools to identify and differentiate the injury and its various manifestations? And knowing that not every injury is the same. So over time, we learned that this is not a one size fits all kind of injury here. And then have been in the last, I'd say, 10 years or so, really moving on to how do we help someone treat the problem? How do we help them recover? We've moved from, as you're going to hear me talk about, a rest-based, kind of way of treating this to now a more active rehabilitation model. And we do that in the environment that the individual, is operating within, whether it's a work environment, whether it's school. We certainly want the social interactions, and you're going to hear us talk about physical activity, and it's important. So over the years, from literally not even understanding what a mild TBI is, and I remember literally the first time I was referred a kid, I was working in Baltimore at the time. Turned out it was a friend of my daughter's who was an equestrian. And I remember thinking, she's back in school, she's doing okay. And the contrast with the kids that we saw at the rehab hospital that I worked at, was pretty significant in terms of just the presentation and the support systems. And we really did not have tools to identify ways of understanding its manifestation, treatment plan, a treatment process, or even how to kind of apply that to the various recovery environments. So we've certainly come a long way over this time. But as always, what happens is kids seem to lag adults in the process of understanding. And certainly, if we want to take the modal 35-year-old, the 15-year-old, and the 5-year-old, I would argue that even our youngest kids have probably still not, we have not still fully understood some of the injury manifestations and treatment methods there. So as a little bit of background basis to this, let's talk about what this injury is. We know that a mechanical injury or mechanical force and energy is applied to the head, from outside the head, and it results in the movement of that brain that I'll talk about and show you in a second here, but produces a number of things, either confusion, disorientation. In the standard definition, we talk about mild TBI being a loss of consciousness of 30 minutes or less, or post-traumatic amnesia for 24 hours or less. As it turns out, most concussions don't even come close to that in terms of loss of consciousness or post-traumatic amnesia. but can also bring on other transient neurological abnormalities, focal signs. My arm, my leg seems to be operating a little bit differently, or certain symptoms. In some cases, typically, very small number of cases, could bring on seizures. And again, we've used this Glasgow Coma Scale idea of the quote mild TBI being at the highest level, being 13 to 15. By the way, there's going to be a conference at NIH next week that is going to look at the question of reclassifying kind of this whole spectrum of injury, traumatic brain injury, because we know that using a Glasgow Coma Scale is a very, very rough way of going about doing this. What happens then is that brain is disturbed in its function, and the good work of Chris Giza and Dave Hobbs at UCLA have really taught us that this is really much more of a metabolic, neurometabolic problem rather than a structural tearing the tissue kind of problem that we see in our more severe injuries. And typically, as a result, we don't see much on a CT or an MRI, a standard MRI. These are normal structural findings. When we do a CT scan, we do it because we're worried about it not being mild TBI, whether there's a bleed or other kind of structural problems going on there. And as we know, concussions oftentimes do not involve a loss of consciousness, and typically, 10% or less actually do that. This is a representation that one of my colleagues at Wake Forest put together, really showing what is the stretch and strain effect. In essence, when the brain takes that force, what it does is it stretches and it strains, less so, kind of a macro structural tearing or damaging of the tissue. But it certainly affects then, as Chris Giza's work has shown, effects on the cell itself and the chemical concentrations both inside the cell and outside the cell, and the electrical conduction. So, these are what we refer to here as software injuries that I'll talk about a little bit more in a minute here. But what that disturbance of function does is it produces a change in our physical, cognitive, emotional, sleep, and fatigue related functioning. What we know is that these injuries vary widely in terms of their length of time. They may be a few minutes to a few hours. They may be a few days, weeks, months. And what we're trying to understand is, why is there that degree of variability? And what we know is that part of it may be the actual force itself, but there are other factors that seem to be playing in as well. These are recovery curves that come from the largest epidemiological study to date, called the 5P study, conducted in Canada. Roger Zemek was the PI, and I participated in this study, and they used the tool that we developed, the post-concussion symptom inventory. And what we see is that in the 8 to 12-year-olds, roughly 89% of those kids are recovering by 12 weeks. And what we see in adolescents then is about 86%, so a little bit less, recovering by 12 weeks. In the study that, this 5P study, when they looked at 4 weeks, they found that the total sample had about 70% recovering by 4 weeks. And I think that's important, because that means that if we're going to get kids back into school, we need to put supports in place, because it's going to likely be a matter of weeks for a number of them, and maybe even longer in their recovery, and the need, therefore, for support. Over the years, there have been these international conferences that have taken place. One is sport related. Certainly, the CDC has a big meeting and a big literature review that was done and published in 2016. In the sport conference, we wrote this paper, Gavin Davis, Vicki Anderson, and colleagues, to really look at what's the difference between kids and adults here. And what we think is that the duration and the prognosis seems to be a little bit different. And understanding that we are comparing kids largely to a group of athletes, because the biggest research that's out there on concussion or mild TBI is oftentimes in athletic populations. So you're talking about a little bit of a different control sample, so to speak. But what we find is that kids may take 4 weeks or beyond to recover. We used to use the 7 to 10 day rule. Well, that was based on a different population. We now have better assessment tools, and I'm going to talk a little bit about those that help us to understand this better. We now are really in the active treatment phase. Kids should not be sitting around in dark rooms. They need to get moving. They need to start to do things. And we've talked now, as we did in this paper in 2016, the need for active school management. And I'll talk a lot more about that really, because this is really the kid's job and what we need to do to support that. And we've talked in this paper about all kids needing to have, or all schools having a policy in place and offering proper accommodations and supports. Laura Purcell, Gavin Davis, and I then went further beyond that and really were interested in looking at what factors should be considered here in returning kids to school. What strategies should we put in place? And so this is just the conclusion statement, but what we said is that schools should have a policy, meaning there should be policies and procedures for what happens when a student is identified with concussion or mild TBI, that we really need to then make some accommodations that are specific to their needs, which means we need to understand those needs and evaluate them. And that starts certainly with a communication from the healthcare provider that helps to identify and define that injury and its manifestations here. And that there is ongoing follow-up to look at recovery progress as the student continues over time. That kids may require a temporary absence from school, and I'm going to talk a little bit about an important study that helps to define what temporary means there. And that we also need to understand that the injury happens to different kids, different people. There may be risk factors and other modifiers that play a role in prolonging recovery, and we need to take those into account and put the proper intensive academic supports in place. Just to mention here, again, there's some very good guidance out there. As I mentioned, the CDC in 2018 published its guidance for pediatric mild TBI, produced a set of 19 statements. The concussion support group, as I mentioned, in 2023, sort of folded kids inside of their adult model, and we are recommending that we not do that again. And then the Ontario Neurotrauma Foundation having their living guidelines that really try to update the guidelines and recommendations based on what the current research is. So whereas the concussion and support group meets every 4 years, we'll have to see when the CDC meets next. Ontario Neurotrauma really tries to follow this over time. So the importantly, as I mentioned, when do we get kids back to school? This is a paper that Chris Vaughn in our group here at Children's National helped to lead, and it used the 5P data set, and it was interested in looking at whether there was a time frame that was supported by the research evidence. And so they looked at what the relationship was of returning to school relative to that symptom outcome at 2 weeks post-injury. And so the question is the timing of return to school after concussion associated with the symptom burden at 14 days post-injury? And found basically that kids that did not return to school after, and you'll see we recommend, maybe 2 to 3 days out, those who return to school later than that tended to have a greater symptom burden that, can be detrimental to recovery and certainly to their returning to school. Now, it's important to recognize that we actually equated the overall number and severity of symptoms in the groups. So it's not just kids with worse injuries and more symptoms that stayed out longer. They were actually equated for that. It seemed like the timing of return was really the factor here that played a role in whether kids were going to be better at 2 weeks or not. So the recommendation then was most kids can and should return after just a few days absence. But what we need to recognize is that this is with understanding of the injury and individualized supports built into that. And I know that that's no small undertaking. And we're going to talk about how we can help to improve that understanding and individualized supports. But the bottom line is we are sending kids back to school symptomatic. There seems to be an important role for their re-engaging in their normalized environments, but need supports to do that. In 2017, I wrote a chapter. It was kind of a soup to nuts chapter here on what are the kinds of things one can do to help kids get back to school. And I can make this chapter available to any and all who are interested. But what the idea was, I wanted to kind of go through the various steps from literally the day that the school is notified about an injury to the point of recovery and return to full academic participation. What are the kinds of steps and processes and personnel that we need to put in place here? Because I do think that a good, again, policy procedure that's systematic is critically important to this process. So let's talk about a little bit how this concussion manifests in school and what we've learned over time. So, when we do a clinical examination of a youngster with a concussion, we look at the signs, that is what has been observed, and we see cognitive, physical, behavioral, emotional kinds of changes that occur. We also know that there's a variety of symptoms. That is, when we talk to the person, what are they experiencing? The headaches, the fatigue, that sensitivity to light or noise, things that we may not be able to see as directly. It's important that we combine both the signs and the symptoms together here. But certainly on the cognitive spectrum here, the fogginess or fuzziness or difficulty thinking clearly, concentrating problems, difficulties kind of processing new information and committing it to memory, just being slower in your overall processing here. We know that sleep can be affected, which of course, factors into those issues there. Emotional response to the injury, oftentimes irritability or greater emotional response, to stresses. So all these factors are what a youngster potentially comes back into school with. When, as clinicians, we were noticing that kids in our practice were reporting different kinds of issues. And so back in 2015, even before that, we started to ask kids more explicitly what were the nature of the issues that they were experiencing. And so we had a sample of 349 kids across the full age spectrum, 5 to 18. And we asked them to tell us about their academic concerns and problems with a structured questionnaire. And we did that within 4 weeks of their injury. We had a group of kids that were actively symptomatic, and we had a comparison group of kids that had recovered from their injuries. So they had experienced concussions, but they were now recovered. And what the study showed us is, and we published this in pediatrics in 2015, was the types of academic challenges that kids were experiencing. We found that the non-recovered kids, compared to the recovered group, reported higher levels of concern and worry about their return to school, more school-related problems, and I'll talk more about what those problems were in a minute, than the kids that had recovered. High school students reported higher levels of problems than middle and elementary age kids, although the younger kids were not devoid of issues here. And that we found that, in fact, higher symptom burdens, that is, kids having more symptoms or more severity in their symptoms, were associated with greater academic problems. And that's important to know, obviously. And that the kids in the non-recovered group were more impaired on their cognitive testing than the non-recovered group. So it was the first empirical evidence of this concussion's impact on the learning and performance as reported by the students. So it identified some academic effects that we really needed then to target in our intervention supports. And these are some of the problems that they reported. And again, split up by the level of schooling, elementary, middle, and high school. And what you can see is headaches interfering, difficulty paying attention, feeling too fatigued and tired, homework just taking them a lot longer to do, difficulty just understanding the material, and studying for tests as well as taking notes. And what you can see is that from elementary through high school, this is the average number of problems reported out of these 7 across the school grade spectrum. You see more and more problems over time, with 4 out of 7 on average being reported by high school students. We asked them, what sort of classes or subjects they were having troubles with, and we found that math was the #1 culprit, but at the same time, reading was also a challenge, as well as other areas of science, social studies, foreign language. We can see that our art teachers are doing a great job, and kids are not feeling that they're having trouble in art. But what you can again see is the increase over time, based on their level of schooling. So then we wanted to look at, can we predict an academic outcome? Can we look at what are the factors of the injury that might tell us that somebody's going to have more troubles? So we published this paper in 2016 that looked at this prediction model. And what we found with this particular study, this is using ROC, or receiver operating characteristic curves. It's basically a statistical method used to predict an outcome. And we looked and we grouped kids on those academic problems that we mentioned before, those 7 problems, as kids that had the lower number of problems, the kids that had the higher number of problems. The lower number of problems in the good academic outcome group, and the challenged academic outcomes was the kids with the higher number of academic problems. And what we found is that again, the number of symptoms that they reported and the degree of executive problems, or sort of managing their learning, were the most predictive. That was the lines that bow out the furthest. The red line that you see right here was actually what we refer to as the exertional, meaning when we tested these kids, we asked them how much their symptoms worsened with that cognitive activity. That was also a significant predictor. And interestingly, their test performance was the least predictive. It was really their symptoms, both dynamically and over the past few days, that really predicted that outcome. So that tells us that we really should be using that symptom process in planning our supports for kids. So what we want to do now is to talk about how we translate this symptom profile into individualized symptom-targeted school-based interventions. So again, we've got this whole array of symptoms that are there, and we can look at these as the targets for our supports. When we look at how these symptoms play out, these are the kinds of ways that we've learned over the years. Attention and concentration problems, obviously affecting focus on a lecture or classwork, or being able to complete your homework, difficulties holding on to information in short-term or working memory now. Information slips away, so now I'm having troubles kind of holding on to the new information, or I might be kind of more distracted with other things, having difficulties retaining new information or accessing that information when you need it. Slower in your pace of being able to keep up with work, as well as tiring more easily and feeling much more kind of foggy or lack of clarity in our thinking. Physical symptoms, certainly the pain associated with headaches, the difficulty with nausea, distracting one, or really the environmental effects of light or noise really affecting the ability now to tolerate the environment. Or just mobilizing, around your environment. If you have dizziness, lightheadedness, spinning feelings, or balance problems, those are all things that can affect a person. And then, of course, their emotional response can be affected, and then therefore interfere with school itself and the ability to sort of have that positive emotional energy devoted toward your work. And finally, the energy issues here, sleep-related issues, or just the drain and the energy. One of the things that Chris Giza learned when he looked at the neurometabolic dysfunction is that the mitochondria are really the battery power in the cell is affected. And over time, it improves, but certainly that lack of energy, that drain, has a biological basis to it. So based on the findings of all these studies, what we did was to develop a systematic assessment tool, and one that I'm hoping I can convince you all to start to use. It's free, it's available, and it really is a way to assess for that individual student, what are the issues that you're experiencing. We call it the CLAS, the Concussion Learning Assessment and School Survey. And we've piloted a number of versions over time, and have arrived at a psychometrically sound tool called the Class 3. And what it is, it's a dimensional rating scale that quantifies, first of all, the student's overall concern that the injury might affect them. So that's kind of almost like the anxiety factor there. But also then scans a broad range of possible academic problems. It's what we did is we took those 7 areas in those original studies and we expanded them out to 14 areas, and kids rate them on a scale of 0 to 3. We also looked at school-related stresses that were experienced by the students, and the potential academic subjects impacted. So you're really getting an idea of what kind of academic problems does a student feel like they're experiencing, what's stressing them, and in what subjects. And so this is the tool itself. And so we ask the question, since your concussion, how concerned have you been that this injury is affecting your performance? And then here are the 14 areas that can be affected. And what we do is we ask them, since the concussion, because the concussion, tell us whether you've been having these school problems, and it can go from not worse or not a problem to a little bit to somewhat to a lot worse. And so it's basically a 0 to 3 scale with 14 items. And so the total scale is 42. We also ask them the question about the stresses. And these are the 6 areas that we identified, again, on a 0 to 3 scale here. So missing time with friends, not being able to do certain things, not feeling like they're getting enough support from teachers or at home. And the big ones that kids oftentimes are responding to pretty strongly: stressed out or overwhelmed with schoolwork piling up, or about their grades dropping. And then finally, we ask the question about what classes you're having the greatest challenge in, from none of them, no different, to a little bit worse to a lot worse, versus just not taking it. We then ask, what sort of support do you think you might need, and are you getting? And so it kind of gets an idea from the student's perspective, what they think may be helpful to them. By the way, we do this scale for kids starting at the age of 10 and moving forward. But certainly, and our colleagues in Oregon have adapted this where teachers can complete it. And we also have a parent version as well. So in order to one of the things that I like to do is not just make up these scales, but to demonstrate that they have reasonable reliability and that they're valid for the purpose that they're developed. And so we published this paper that provides the psychometric support for the tool. And what that told us was that, first of all, the content of the items was really drawn from clinical experience with kids, and from the 2 published studies that I mentioned, the 2016 study. We found that these 3 scales have good consistency within them. What that means is that the items within the scales are cohesive, they fit together, that the scale scores are moderately stable over time, meaning that they don't just wobble on their own just based on a lack of reliability. The self-report and the parent, the inter-rater, that is the similarity between a parent and a student ratings was moderate, was pretty good. And we usually find that those correlations are somewhere between 0.3 to 0.5, so they're kind of moderate. And the scale certainly met that criteria. We did some factor analysis just to look to see did the scale itself shake out the way we thought, and it actually supported that. And we found too that the way kids rate these problems have reasonable relationships to the symptoms that they're experiencing as well cognitively in sort of their learning. And that over time, the scale does show a sensitivity to change. That is, as kids are getting better, they are also reporting that they're doing better in their academics. So the scale itself demonstrated some good sort of scientific psychometric characteristics to it. So if we think about this, then if Roger Zemek's study, which shows that 70 plus or minus % of kids are going to take up to 4 weeks to recover, and if we see that when you go beyond that, somewhere between roughly 10 to 15% may take several months to recover, we need to think about building recovery supports into a kid's return to school pretty much from day one, and plan on those supports. As I said, a smaller number of students will likely need those supports for a little bit longer, but at least we will have them in place. And one could argue that the earlier you have them in place, probably the better they're going to do with their overall school performance. So I also want to talk about some of the things that as both educators and those that support kids in education, some general principles and procedures that we can really reinforce with kids. And these are questions that we can be asking. And I talk about recovery enhancing activities for all. I think it's important to know that we have learned over time that there are activities that definitely help recovery. Also, to establish a pathway, as I mentioned before, that chapter that I wrote established the pathway from literally day one, learning the injury out to recovery, and really being able to track that recovery over time, and using, again, things like the tools, the class 3, to track both the symptoms and the academic manifestations over time. And to make sure that we're implementing these supports across all aspects of school and all aspects of their environment. So here are the things I think are really important for us to understand. And these are the things that we really work very hard in clinic to reinforce, but I think it's important for the school to appreciate it as well, because some of these things can clearly be affected by a youngster being in school. So again, as we say, we want them back early, but we want to support them. We want to make sure that kids are getting good nighttime sleep and not staying up late. And from a school perspective, that would be doing lots of homework that is keeping them up late. We know lots of kids work very hard and are up late into the early hours of the morning sometimes. We also tell kids that we really want to minimize daytime naps. We want them to put their sleep effort into nighttime. It's important to keep that sleep-wake cycle going. 3 meals a day. We tell kids you've got to get breakfast in you, and you've got to get that lunch in there and dinner. It's important because this is an energy deficit injury. As I say, the battery power in the cells is really looking, and some of the other neurometabolic factors are really looking for energy to help it recover. And if you eat dinner at 6 o'clock at night and don't eat again until, say, 11:30 or noon the next day, you've gone 18 hours without that energy. So you've got to build good, steady energy across the day. Hydration. Kids need to bring their water bottles. They really need to do this. I know that's more acceptable these days in school, but some places still don't kind of allow that. We tell kids, and if you think about it, most teenagers are more than 100 pounds. We tell them that you need to have at least 80 to 100 ounces of fluid, water. You can have juices, you can have Gatorades, nothing with caffeine though, or I shouldn't say nothing, but certainly caffeine cannot be the predominant liquid that you have. So very important. Managing the daytime activity. This is really where school comes in. So the PACE model that we used is an acronym called Progressive Activities of Controlled Exertion. So you're over time, you're doing activities, progressing, and you're controlling your exertional activity. So we use our symptoms as our guide. We want to know when we've done too much, that symptoms blow up. Okay, we need to take a little bit of a break. But at the same time, we don't want to do too little. We want to engage with what our symptoms allow us to do. We want to take our day in doses, meaning that we want to probably build breaks into the day, doing an activity like a class or two, and maybe needing a rest or what I call a recharge break, and tell kids it's the mitochondria that you're recharging there, and then get back to the class and then take the recharge break. So it's very important that we think about the managing the daytime activity, managing stress, helping kids to focus on the positive, what they are doing that they can control. And also in schools, making sure that we don't overload kids. We know that schools are demanding and they need to be, but as we're recovering, we're really trying to manage that carefully over time. And then encouraging gradual physical activity and exercise. And we encourage the kids to start that really in the middle of the first week by walking, by doing things that are movement oriented. Now, when you have kids with significant dizziness or balance problems, we have to be careful about that. But for those that can handle that, we want them to get them moving. So those are the things that we need to monitor, and for school nurses, for athletic trainers, but even for a teacher, to make sure that the youngsters getting lunch, they're remaining hydrated, that we're reducing the stress, that we're allowing those breaks to be taken over time, and that we're really encouraging them to get good nighttime sleep, to cut off homework by a certain period of time so that they're able to rest well. So, and then this is the pathway worksheet that I mentioned that's in that chapter, really from the point of school notification to the healthcare provider, hopefully communicating and generating a return to school letter, a plan being considered for when the student comes back, there being someone that's going to help monitor the symptoms and the academic performance, communicating with the teachers, monitoring that over time, adjusting supports as the symptoms allow. And I'm going to talk a little bit more about this. There are times when we do actually think about kids not returning full-time into school, and that's usually those kids with more substantial symptoms. Let's get you back to school partially for maybe half a day. But then think about how we stage the level of supports from a full day and maximal supports with minimal to moderate expectations for productivity. I tell kids in those stages 1 and 2, your main job is to attend school, to try to get as much out of it as you can, but to start to get back into the flow. Again, how much homework the kids can handle will depend in part on again their symptom status, and so we look at sort of decreasing those supports over time as they improve. So that means we need to monitor those kinds of things. We've built something called the STAMP, the Symptom Targeted Academic Management Plan. What we see is that on the left side here, we have symptoms. They can be cognitive, physical, emotional, fatigue, and the kinds of problems that we might see in school and the kinds of supports that can be generated. Now, let me just say this, good creative people can generate other kinds of management strategies or accommodations. We put down some of the more obvious ones, but the idea here is that we want to look at these symptoms as the targets, and we want to build then the supports over time that help to manage them so that the youngster can optimize their time in school. And of course, we want to monitor that over time. We know that kids do, in fact, improve. I mean, they definitely get better. And so we know that the need for academic supports will decrease in proportion to their recovering symptoms. I've had kids say, "Oh, I still want the breaks." And I said, "But you don't have fatigue or headaches anymore. What are the breaks for?" "Sorry, we're not going to give you just the time off. We want you to get back into as much of the normal school as possible." Most kids aren't asking for that. Most kids want to get back into their normal activities. But it's really important, again, that we monitor symptoms using a standardized symptom scale, and we monitor their academics using something like the CLAS 3. And we adjust the number and the intensity of supports accordingly. As I say, it could be the number of rest breaks that they need for various kinds of issues here. They may need extra time because their attention is just not as focused. They're slower in their performance. They may need things like sunglasses or earplugs, because the stimulation is getting to them. Or they might need to sneak out of class a few minutes early to get around the busy hallways or a little bit afterwards. Or they might need to be having lunch, say, with a couple of friends in a quieter place than the busy, overstimulating lunchrooms. And again, they may need some emotional supports, both from the regular classroom teacher, maybe from the school counselor, depending on sort of what level of either anxiety or frustration they're experiencing. And it's important to also recognize that, this is something that affects kids psychosocially as well. It's an invisible injury, as we say, so it may not be fully appreciated. They may look normal, and most kids want to look normal, but that doesn't mean they're not experiencing the symptoms. We're limiting certain activities they can do. They may not be with their friends as much. They may not be on their teams as much or their activities as much, and so they're sort of isolated from their group. It may relate to their identity that I am the main person in the play that does this. I can't do it, or I'm really important to my friends in this club or in this sport, and right now I can't be the one, and that's hard to handle. And of course, everybody wants to sort of be able to be back to their normal self, to contribute, and so there's an internal pressure people will feel to return that, or again the pressure of a lot of schoolwork. So all these things we need to take into account and to support around. So as we've learned, and really the kids and the families have taught us, we've sort of built that back into some key messages that we think are important to help to really increase a youngster's confidence in taking control of their active recovery. And so we coach them up and tell them, you're going to get better. You are going to improve and you are going to recover. You take control of the things that you can control. That is your activity level. And once you do that, it will pay off over time. You need to find that sweet spot, what I can do and what I can't do, and know how to manage that. And we teach self-control, how to, again, recognize symptoms, but not be overwhelmed by them, and to work with them. So really, giving that positive message, really building that self-confidence that you can handle your recovery is very, very important. In doing so, we decided to develop another scale that really helped us to understand what stage was that individual in the recovery process. And it's very important that they be positive so they can actively participate in their treatment plan. And we know that varies widely between patients and families. And so, one of the things we want to do, and I do a fair amount of education on what this injury is and what it's not. It is a software injury, meaning it's the electrochemical systems, and we can affect and help its recovery. But we can also interfere with it if we don't, take care of ourselves. And so we really tell them, how you feel and the confidence you feel is going to help you in your recovery, and we're going to help you with that. And so to do that, we developed a scale, the PACE self-efficacy scale. And what we do here is we ask kids to basically rate on a scale of 0 to 10, from not confident to highly confident, how they are feeling in terms of managing their stress, managing their activity, getting adults to help out, and maintaining a positive outlook. And it's very important that we look at these things because it's a good barometer of whether that youngster needs some supports. And so we built this scale in such a way that we wanted to really identify, again, the whole idea here is, can we say that this is a scale that has reasonable reliability and validity? We found that a set of items, those 3 items, tell us about how they manage their stress. We found that managing their activity across the day was important. And they have 6 items here. Like, for example, I know when to take breaks and when to push myself. I can identify which classes or activities do not increase my symptoms. I can find the right amount of activity that's not too much and not too little. When to seek help from adults. Can parents, teachers be of assistance, and are you seeking that out? And are you maintaining a positive outlook on your recovery? Like, I can continue to do things that I enjoy even though I have a concussion. I can tell that I can do more since I was first injured. I can stay positive during my recovery. Important to gauge those things. And so we collected data on a large sample of kids, and we looked and found that the scores are stable, that they're associated with recovery in a positive way. They're also very much associated with academic So we looked at it relative to the class 3 and found that greater academic learning and performance problems was associated with lower self-efficacy. So the supports really, it's sort of a cyclical thing. You build supports, you build confidence. You build confidence, you use those supports. Very important to do that. And we found that when we compared recovered with non-recovered patients, they definitely differed in terms of their degree of confidence here. So it's important to sort of monitor these things along the way. So how do we make it happen? This is the last few things I'm going to talk about, and then we're going to summarize and take a few questions here. How to make it happen? So we really need to have a school-based concussion management. And the goals of a proper, school return is that we have medical folks that understand schools, and I know that can be a challenge, and we have school folks that understand the concussion, and that has its challenges with it. We want an initial medical evaluation that is communicated with the school, and that kids are being returned to school in a timely manner, as I say, within that first week of that injury. We want a school concussion management team that translates the symptom profile into the academic supports, identifying who those people are. We want regular monitoring so that we can see how the person is doing. There may be areas that we need to build up more supports around because they're not making progress. And then we want to readjust the supports over time with progress or without progress, and to communicate that amongst the family, the medical provider, and within the school, and certainly within athletics, if that's what the youngster is involved in. So having good communication between the medical provider, we have our return to school letter. The CDC has an adaptation of this, a return to school letter. We've got, again, that gradual return to school guide and the kinds of things that we might do here. We have the stamp. So all these things that we can build in that are helpful to communicating the needs of the student, we need to put in place, but we need to have the players involved. We need to have, whether it's a school nurse, a school psychologist, an athletic trainer, a guidance counselor, administrator, or certain teachers, all can potentially play a role. Someone needs to really be responsible for monitoring that symptom status in school over time. Also monitoring the academic status, how is the youngster doing? Are they learning? Are they performing? And there needs to be communication both within the school team across all subjects, but also with the family and the physician, so that any adaptations or encouragement or greater supports need to be put in place. So healthcare provider, plays an important role. They know the injury, they do the diagnosis, they can help to define some of these needs, but the school is really the expert now and needs to translate it into the supports to optimize that. So it's important that there be coordination of these elements. So again, let's consider this. Now you sustain a concussion at a school-related event. The concussion is diagnosed at the emergency room and your primary care doctor is informed. But your doctor contacts the concussion management team, that representative at your school, and details your current symptoms. The CMT plans for your return and coordinates with each teacher based on your symptoms. They use tools like the class 3 or the PACE self-efficacy scale that details the areas in need of support, and a plan is developed and communicated to all the teachers. Your job as a student is to learn and perform as best you can using those individualized symptom-targeted supports, and not doing too much, but not doing too little. Now you feel relieved and understood, and you watch your school softball team today after school, if you feel up to it. So there's things we can definitely do. I think we would argue that student would feel more supported, more understood, and more in control of their recovery when the system is all working together. So, in summary, concussions, a force to the brain affecting, again, the electrochemical software that impair these various functions. The brain works hard to repair these things, and we can assist this process, again, with those recovery enhancing activities, but it can also be interfered with if we don't provide the enhancing activities. We know that most students are going to recover within 1 to 4 weeks, but some take longer. So concussion effects clearly can affect school learning, as we've found here. Schools need a team to provide that systematic coordinated support services, and that can be folded into the RTI, MTSS, 504 systems, whatever your school is using. And the treatment approach, again, is generally speaking, day or two maybe out of school with relative restriction of activity, making sure they're getting nighttime sleep, hydration, eating, to then move toward active, progressive um, um, supports, monitoring symptom management, and returning kids to school, roughly 2 to 3 days after the injury has happened. But we need to define the unique symptom profile. We need to take the type and severity of those symptoms directly related to the effects on academic learning. How is that related? We can use tools such as the CLAS to define those academic ways, as well as the psychosocial effects using the PACE and translate them into academic supports. Tools like the stamp are there to conduct regular evidence-based monitoring and adjust the types and intensity of supports as the youngster requires. Okay, so we know that concussion care is a team sport. Communication, collaboration, coordination with the family and with the medical providers is really important here. We want to establish that team that can help manage these injuries, implement a good school return to school policy and pathway using our CDC recommendations for return to school, make sure that medical and school expertise is coordinated and collaborative. Students will then improve with this systematic evidence-based supports. All of these factors are very important as we think about helping kids that have sustained this injury. So just to tell you too, we have videos that are available. We're doing a little study. I can tell you more about it if you're interested, but given the short time frame, I want to let you know that we also have a sort of a treatment guideline update. I can send this on to you all that talks about what's the evidence behind rest versus activity, exercise, school and cognitive activities, symptom-specific treatment, and information that parents can have. Our good friends at the University of Oregon, Dane Ramshaw, has helped develop 7 videos. Ann Glang and her group helped develop the 8 tip sheets to guide management here for headaches and stress and sleep and focusing on school, all these kinds of things. And so all these things are available to you all to help support kids come back. And that is my contact information. I know we are coming up on the hour here. I'd be happy to take a question or two from the group.
Yeah, Jerry, you have a couple. Somebody was asking if there's an equivalent or close to a version of the class for adults for returning to work, planning, and management. Do you know of any?
Oh, that's a great question. I don't know if there is. I would hope there might be. When we built the ACE care plan, we built one for adults, but we didn't build that. So I am not aware of one necessarily, but it could be adapted. It
I
certainly
don't
could.
know of one either. There's yeah, no. Let's see. Then where is the class 3 available?
I will send it on to Siebert, and
Okay.
Siebert can make it available as you wish. And again, I'll send those things on the PACE. Happy to send on the chapter, those treatment tips, all those kind of things. So you've got a library of materials available to you.
Yeah, and we'll send it on. This one is, have you provided the return to school information to school districts? Is there a way to provide this information to our local school district?
Yeah, I mean, I think, we're going to send you all that information. Now, what we need to do is find ways to, kind of do seminars, some sort of educational opportunity to teach our schools, because it comes down to the school building, and who's the champion at the school building, and how do we get that moving?
Yep. And then let's see, what is the most important messaging and education that needs to be shared by concussion programs with clinicians outside of the concussion program? So what is the most important messaging that you would want to share?
Number one is we now have ways to help kids, both in their school and non-school lives. They will get better, and it's directly proportional to the supports that we provide. And maybe the subtext is, let's identify what those issues are. One of the things I didn't talk about is the kids that have, sleep problems before the injury, that makes things a bit more complicated. Kids that have some learning challenges, attentional issues, it can be compounded by the injury. And those are things that do require probably a little bit more specialty support. Some of those kids may already be, either in a special education program or getting 504 supports, those kinds of things. But these things kind of, build upon it. So I think it's important to know that we have ways to assist kids that have some good evidence and demonstrate it. And so, get the right people in place, get the right tools in place, get some education around how to use them, and you will really help kids in their recovery.
Perfect. Okay, one more question. If a student athlete is recommended by a medical provider to complete a neuropsychological testing in order to return to play, what does that entail and what kind of provider can do that?
Oh boy. So that depends, because I'm not sure so there are some tests that are out that have been used that are kind of neuropsychological in nature, that do help us know whether cognitively the person has returned back to their normal levels. The challenge is you need somebody that's reasonably trained to do those tests. Again, it's possible that a school psychologist could do that if they have some training in this. Ideally, that would be the thing, because we know that pediatric neuropsychologists are not necessarily a dime a dozen, so we don't want to hold people up. So the main areas that we look at are attention, concentration, memory, speed of thinking, and some of the executive systems. And so I think that your community needs to identify who those concussion practitioners are that can do that. Interestingly, the Sports Neuropsych Society has a map. So if you go to sportsneuropsychologysociety.org, it has a map showing you where sports neuropsychologists are, and that might be help. I can't say that we're all over the country, but we're around most parts of the country. So that might be a resource.
Yeah, that would be great. All right, well, I think we're a few minutes over. Thank you everyone for sticking with us. Matt has put a link to the evaluation survey in the chat. If you could quickly do that always helps us. We appreciate the feedback and use it to plan our next webinars and always get better. So on that note, thank you everyone for being here. Thank you, Dr. Gioia. We always appreciate your wisdom and your time.
My pleasure.
So, all right.
My pleasure. Thanks, folks.
See everyone later. Thank you.
Bye-bye.